Hello, my name is Sing Yap. I'm a cardiologist, electrophysiologist from the Erasmus Medical Center in Rotterdam, the Netherlands, one of the largest academic centers doing ablations. We have the full portfolio of cryoballoon ablation, RF ablation, and also PFA. At this moment, having an adjustable balloon size is very practical for doing cryoballoon ablations. So far, we have a large experience with using the 28 millimeter balloon, and we can deal with a lot of PV anatomy. But sometimes we encounter these large PV ostia or common trunks, which can sometimes be difficult to achieve isolation with the 28 millimeter balloon. In those cases, I think a bigger balloon size of 31 millimeter can help to give you a good PV occlusion and better isolation. Furthermore, I think having a bigger balloon size will also help you to get a more antral position. And that is important if you go to the right-sided pulmonary veins, where your balloon size is not sitting deep inside the PVs. And this can be beneficial for preventing phrenic nerve injury. Of course, having a bigger balloon size is not always better. Sometimes a smaller balloon size of the 28 millimeter standard size could also be helpful if you have, for example, have small PV ostias, or sometimes areas where you can achieve difficult occlusion, for example, the right inferior pulmonary vein. In that case, 28 millimeter balloon may be better suited. So having both options at the same time, I think that's the biggest advantage for the operator. If we need pre-procedural imaging, I think a lot of centers don't even do any pre-procedural imaging. Some centers, of course, they do to have a little bit of sense of the anatomy of the PVs. And some centers, they choose to go only for cases where you don't have big or large PVs or common trunks. And in this case, when you have a bigger balloon size, I think that reduces the need of pre-procedural imaging with CT, for example. The 31 millimeter size comes with a little bit higher inner balloon pressure. It goes up threefolds compared to the 28 millimeter size of the POLARx balloon. So that have an influence on the compliance of the balloon when you achieve occlusion. And you can see that, and you can also feel it, where the balloon shape is a little bit different. It's more flatter, the distal part, and that means it sits less inside the PVs. Sometimes that even for big PVs, that's no issue, but sometimes for smaller PVs, it can be less easier to achieve complete occlusion. So again, yes, it's a little bit more stiffer, but if you compare to the competitor, even then the inner balloon pressure is still threefolds lower than the competitor. In that case, it seems to be compliant enough. But again, it depends on the PV anatomy if you choose a 28 or 31 millimeter size, in my opinion. Currently, I use the 31 millimeter standard as the first balloon size. If we see we don't get good occlusion, we will switch to the 28 millimeter balloon size and see if we get a better grade of occlusion. And then we go for the smaller balloon size. But the standard balloon size is now 31 millimeters. The reason for that is, I think, having a slightly larger antral lesion set could be beneficial for reducing atrial fibrillation recurrences. But of course, we need more clinical follow-up data to confirm this theoretical benefit. One thing to keep in mind is that if you have a patient with a small left atrium, then doing wide antral lesions may be not beneficial. If you look at the occurrence of macro reentry atrial tachycardia, due to the fact that on the posterior wall, the isthmus size can be very small, which can give you atrial flutters. So in that cases, where you have a small left atrium, maybe the standard 28 millimeter balloon size should be better.